Good afternoon, ladies and gentlemen. Welcome back to the National Trauma Conference 2025. Our next session explores the art and science of early trauma resuscitation, the critical management of trauma-related cardiac arrest, the guiding principles of endpoint resuscitation, and the vital role of blood products in restoring life and balance. This is where split-second decisions, evidence-based protocols, and seamless teamwork unite to shape survival and recovery. To lead us through this insightful journey, we are honored to welcome our esteemed chairpersons. We warmly invite on stage Dr. Roshan Dasanayaka, Consultant General Surgeon at District General Hospital, Negombo; Dr. Eranda Sanjeeva, Consultant Intensivist at the Neurotrauma Unit of the National Hospital of Sri Lanka.
Good afternoon and welcome you all back to the next session. So the next session is on trauma resuscitation. As you all know, resuscitation is an integral part of trauma management. So the final outcome definitely be determined by the successfulness of initial resuscitation. So I would like to call upon to discuss about trauma reception and triage. It's going to be Ms. S.R. Samarasinghe. She's a triage nurse at the Accident and Orthopedic Service of the National Hospital of Sri Lanka. Over to you, Ms. Samarasinghe.
Now is the time about the touch. As a healthcare professionals, you all know the triage in hospital. So, triage in hospital emergency departments is a vital process typically performed by trained nurses who must swiftly assess and categorize patients based on their severity of the conditions. So, the triage decision making is complex and dynamic process. Decisions are made within a time-sensitive environment with limited information for patients who generally don't have medical diagnosis. Due to the multifaceted nature of the triage role, nurses are required to possess specialized knowledge as well as experience with a wide range of illness and injuries. So, let's move on. A triage system is the basic structure in which all incoming patients are categorized into groups using a standard urgency rating scale. The triage scale is a clinical tool for ensuring that presenting patients are prioritized according to clinical urgency. You all know that triage is an essential function underpinning the delivery of care in all EDs, where any number of people with a range of conditions may present at the same time. The first contact also for all unbooked admission is qualified and trained triage nurse. The trained triage officer performs a brief focus assessment, not taking more than 2 to 5 minutes, and assign all the patients to a triage acuity level, which decides how long a patient can safely wait to seek medical treatment. So, we are aiming with the triage. Triage category helps hospitals that the most serious case first, but everyone who comes to the ED will receive care based on their individual needs. Each presenting problem will range in severity, and assessment in the ED will determine the most appropriate triage category for individual needs. So to get the right patient to the right resources at the right place and the right time is our aim as a triage nurse. All are doing according to their clinical urgency. So what's the meaning of the urgency? Urgency is determined according to the patient clinical condition and is used to determine the speed of intervention that is necessary to achieve an optimal outcome. So urgency is independent of the severity of complexity of an illness and injuries. So this is the triage categories currently practicing in Sri Lanka. So victims who need to have treatment immediately or within 2 minutes are categorized as category 1. Right? So category 2 need to have treatment within 10 minutes are categorized as having an imminently life-threatening condition. And category 3 is people who need to have treatment within 20 minutes are categorized as having potentially life-threatening conditions. And category 4 is go to people who need to have treatment within 30 minutes are categorized as having potentially serious conditions. So what about the category 1? One is go for with direct. Victim is in this category have the most serious and life-threatening conditions such as cardiac arrest, respiratory arrest, ET intubation on arrival, severe respiratory distress with agonal type of gasping breathing, right? So, and the other thing is ongoing prolonged seizures, patient who present unresponsive and or patient may be responsive only to pain. So, and the other thing is severe bradycardia, it may be less than 40, and severe tachycardia, it may be more than 180 beats per minute, and systolic blood pressure is less than 70 with hyperperfusion signs. So, and the category 2, what are the categories? It may be airway risk with severe stridor or drooling with distress, severe respiratory distress, or circulatory compromise signs. So what are the signs? Cold and clammy skin with poor perfusion, heart rate less than 50 or heart rate more than 150, hypotension with hemodynamic effects less than 70, less than 90, within range of the 71 to 90, or severe blood loss, right? So the other thing is major multi-trauma and the severe localized trauma, major fracture, amputation, and very severe pain of any case, drowsy, decreased responsiveness, it may be less than 13. So this is the trauma team activation criteria actually in accident service. So it goes to mechanism of injury and anatomical injury and the physiological injuries. So the mechanism of injury may be motor vehicle crash within ejection, fatal injury in the same vehicle, or fallen from height more than 6 meters, it's about 20 feet, or 3 times in the height in children. Or the other thing is rollover with signs of impact, pedestrian thrown or run over injuries. So what are the anatomical? It may be 2 or more proximal long bone fractures, suspected spinal cord injuries. So amputation proximal to wrist of ankles, significant penetrating injury to head, neck, torso, proximal limb, significant maxillofacial injury with airway compromises. So burns more than 20% total body surface area, or it may be facial burns, and the other thing is the physiological. So systolic blood pressure is if less than 90 with hypoperfusion, ventilatory compromise with respiratory rate less than 10 or more than 30, GCS less than 12 with torso or extremity trauma, pregnancy with 24 weeks with torso injuries, and age more than 70 years with chest injuries. So this is the category 3, going with color called yellow. It may be potential life-threatening. The patient condition may progress to life or limb-threatening, or may lead to significant morbidity if assessment and treatment are not commenced within 30 minutes of arrival. Or it may be situational urgency. There is potential for adverse outcome if critical treatment is not commenced within 20 minutes. Right? So this is the category 4. Right. Category 4 is going to potential serious. The patient's condition may deteriorate or adverse outcome may result if assessment and treatment is not commenced within 30 minutes of the arrival in ED. So it may be symptoms moderate or prolonged. And situational urgency is also goes to category 4. There is potential for adverse outcome if time critical treatment is not commenced within 30 minutes, or significant complexity of severity. So those are the conditions what we are talking about. Category 4, it may be mild hemorrhage, chest injuries without rib pain or respiratory distress, minor head injury, no loss of consciousness, minor limb trauma. So those are the category 4s. So this is the triage form currently we are using in Sri Lanka. So patient data that is collected and retained must be accurate and reliable. So the documentation of the triage assessment should include at least date and time of the assessment, chief presenting problems, relevant history, and relevant assessment findings. Initial triage category allocated. What we are categorizing patients, we need to record all the things in this triage form. So this is the hospital health information management system, includes patient record system, which is also using triage for calculate TRIS. So what's the TRIS? So trauma injury severity score is the TRIS. A trauma surveillance score is a tool used to assess the severity of patients' injuries for emergency triage and to evaluate the quality of trauma care. This uses the revised trauma score as RTS in combination with the injury severity score. It means abbreviated ISS, and patient age to calculate the probability of survival. So injury severity score, ISS, is a numerical score used to assess the severity of multiple injuries sustained by a patient ranging from 0 to 75. So purpose of the revised trauma score is, especially in field triage, is to provide the quick and reliable assessment of the trauma patient's physiological status for field triage and for the evaluation and trauma care and quality. So there are 3 categories we are assessing as RTS, especially blood pressure, respiratory rate, and the GCS. In the severity calculating, we are categorizing body as 6 regions. You can see head, face, chest, abdomen, extremity, and external. So those are the 6 regions we are giving marks 0 to 6, and the system may categorize in and calculate in the TRIS. So that's the TRIS we are doing in triage. So the accuracy of the decisions is important, as the triage category you assign can have a profound impact on patients' outcome and on the use of resources within the ED. So if maybe doing the low triage, patient may waiting for medical attention too long. So it may be harmful for the patient's life. So other thing is it may be over triage. Over triage may be affect the hospital resources, and other patients are waiting for them. So what's the main important thing is, as a triage nurses need to try appropriate triage. So that's the needful thing is the ED. So how is going to triage in mass casualty? So we all know the mass casualty incident in any event resulting in number of victims large enough to disrupt the normal courses of the emergency and healthcare survivors. So once major incident declared, nurses in the triage and information unit, they need to seek following information from the source. So what are the things, what is the type of incidents, magnitude of the incidents, and the probability number of casualties, time and place of the incident, and also telephone number of the important for verifications is the most important thing is collect as triage nurse in mass casualty. So triage nurses need to confirm the incident from police post and the police emergency or army, and need to inform the hospital director in National Hospital. This is according to this presentation has made according to our National Hospital of Sri Lanka, right? So we have to inform the director NHSL and the deputy director in accident service and telephone exchange and chief nursing officer in NHSL, special grade officer in accident and orthopedic service. So we need to dial accident service call list and start triaging patients using color codes. So if the mass casualty is present, switchboard shall dial all the list when instructed by the hospital administration. So they dial page holders, group page messages, and direct line holders, intercom system. So what is next? They are delivering message. This is the message delivering in mass casualty. So in mass casualty, the triage officer will be the consultant surgeon from accident service. He may be assisted by the 2 medical officers with 2 nursing officers in triage. So color code is in mass casualty is little bit different because so red is going to extremely urgent patients, right? So yellow is go to urgent, and green is non-urgent, and black is for the death. So nurse at the triage will apply numbered flags, tags, and color bands to the arm of every casualty, and a color sticker will be pasted on the right upper corner of the front cover of every fold, depending on the severity of the patient. Then hand over folders to the patient. So red is extremely urgent. You know, then they require immediate stabilization care, and green is urgent, may require close monitoring and care. And green is non-urgent, requires delayed or no treatment. Black is dead or almost dying. It means victims have very severe injuries that make survival impossible with available resources. So, in mass casualty, walk-in casualties are directed to surgical, orthopedics, and other subspecialty wards. Critical casualties to be sent to the resuscitation area. The remaining patients are referred to the general wards that are reserved. So, once all the mass casualty triaging is finished, start functioning as information center once phase 1 of mass casualty situation is elapsed. So that's the triage process is going in accident service in mass casualty. Okay, thank you very much.
Thank you, Ms. Samarasinghe, for that very interesting talk on what really happens to the patients right at the beginning. I think we'll leave the questions to the end. Why don't you please sit at the head table? And next, we have a lecture on trauma cardiac arrest, and this will be delivered by Dr. Priya Samarasinghe, who is a consultant general surgeon with a subspecialty training in trauma and surgical critical care at Shoalhaven District Memorial Hospital, Australia. And he is also a board member of the Australia and New Zealand Association for Surgery of Trauma and an instructor in the anatomically based surgical exposure to trauma course. Dr. Samarasinghe.
Thank you. Today I'm going to speak about management of traumatic cardiac arrest. I'm going to give a brief introduction, definition, role of thoracotomy, indications, when not to do thoracotomy. I think that's very important, when to do it, and also about pre-hospital traumatic cardiac arrest, when to do a thoracotomy or should we do a thoracotomy pre-hospital scenario, and also discuss about the thoracotomy procedure and what are we looking into the future when, so these are the topics I'm going to cover today. So first of all, the definition. It's a state of coma, absence of respiration and absence of carotid pulse. So it's very important to identify who are the patients in traumatic cardiac arrest. So there are correctable causes of traumatic cardiac arrest. So we need to know why this patient has gone into cardiac arrest. Is it due to hemorrhage? We see in about 60% of the cardiac arrest is due to hemorrhage. So if we see a patient hemorrhaging, we need to find where the patient is bleeding from and try to stop the bleeding by exposure is very important from head to toe, and also look at the back where the patient is bleeding, and we need to apply pressure. Sometimes we might need to apply tourniquet and start transfusing this patient and get to until definitive treatment, try to stabilize this patient. Next, most common is the tension pneumothorax, which we can see in about 30%. In these patients, we'll have to perform bilateral thoracostomies at the scene. And also whether the patient has cardiac tamponade, we need to see. This is seen in about 10% of the traumatic cardiac arrest patients. And also there could be airway obstruction, which is less common in about 7%. And so basically we need to, as I said, stop the bleeding, get the oxygenation, ventilation, get the cannula in, and start transfusing. If there are no blood products, then IV fluids, and if we can't get IV access, then we need to see intraosseous access as well. And in blunt trauma, we can use pelvic binders. So role of the thoracotomy is, there are two main roles. One is to stop the bleeding from the chest, and also it can be used as a resuscitative procedure, we can use it in penetrating as well as blunt trauma, but in penetrating, survival is around 7.9%, and in blunt it's very much less, 3.3%. So we need to know when to use it and whether it will be useful in each of these scenarios. Who are the patients we are going to perform thoracotomy? So we need to make sure like it is a witnessed cardiac arrest, not a patient who has been in asystole for a while. So in blunt trauma, we need to see whether this patient's went into cardiac arrest less than 10 minutes to perform the procedure, and in penetrating, it should be less than 15 minutes. So this timing is very important when deciding who should get the thoracotomy. So goals of this is performing the thoracotomy is mainly hemorrhage control from the chest. Also, if there is a cardiac tamponade, to release that, for open cardiac massage, and also exposure of the thoracic aorta for compression and get the circulation to the heart and the brain. And also when you compress the aorta and when you give the blood products, the preload, and give cardiac massage, we can usually resuscitate the patient. And also this procedure is done to repair cardiac and pulmonary injury. So this is an important slide actually, because when not to perform. If the patient has vital signs, the patient should not have a thoracotomy. And if the patient has non-survivable injuries like severe head injury or severe multi-system injury with non-survivable injuries, these patients should not proceed to a thoracotomy. And if of course, if the patient is in asystole more than the period I mentioned earlier and has no signs of life and there's no cardiac tamponade, then it's not worthwhile doing a thoracotomy. And also it's important to know the resources available. Just performing a thoracotomy in an institute where you don't have immediate operating theater or surgeons available or blood products, it's not worthwhile doing this procedure. And need to have the appropriate equipment and training of the medical staff to do this procedure. And also in penetrating abdominal wall without cardiac activity, it's not recommended to do a thoracotomy. And also it depends on the age of the patient. If they are pediatric, between like infants to 14 years or adults more than 57, it's not recommended to do a thoracotomy, but these ages might change with time. But according to this paper that I have quoted, this was the age range that they mentioned. So as I said, it should be performed in a where you have an operating theater immediately available, and the person who is performing the thoracotomy should be accredited to do the procedure and being allowed to do this procedure, because it's a quite morbid procedure. And also the indications need to be met without any contraindications. And we need to know that doing thoracotomy carries risk to the person performing the procedure as well as to the patient, because the rib ends are sharp and you can get injured by performing this procedure, and also we do it very quickly, this procedure, so we can get injured doing this procedure. And also it is quite morbid to the patient because we are cutting the chest wall, and usually when they are in arrest they don't bleed much, but when you get the circulation going, it's going to start bleeding from your internal mammary artery and from the cut, and they are going to further bleed. So it's important to know, and also the procedure itself can injure the heart, the phrenic nerve, the aorta, especially if you cross-clamp the aorta. It can injure the aorta, so sometimes compression is better. And also when you keep the clamps on for some time, it can cause ischemia to organs. So we need to be aware of that as well. So it's important to know the principles, focus of, now I'm going to just speak about the pre-hospital scenario. So it's important to bring the patient to a place where there is definitive management, and not to prolong on-scene time. And also thoracotomy may be considered if, of course, the patient has witnessed cardiac arrest in the pre-hospital, but then we need to look into the indication, contraindication, resources, and the training of individuals in the pre-hospital scenario. But then I look at the next papers, which had looked at the in England, East of England Ambulance Service, HEMS, they cover a population of 6.2 million, and they did thoracotomies because the hospital transfer took times were longer. That's the only why they performed the pre-hospital thoracotomy, because there weren't immediately hospitals were not available, so they had to transport the patients by helicopter. So before that, they, in some patients, they had to perform pre-hospital thoracotomy. And this study was done from 2015 to 2021. They had 44 thoracotomies performed pre-hospital, 26 for blunt and 18 for penetrating, and there were no survivors to the hospital. So it shows that always this is not a good idea. And then in the US, in the Journal of Trauma, in 2022, this paper was published where they compared penetrating wounds, patients with penetrating wounds who were transported by police versus emergency retrieval teams. And they found that immediate transfer to a hospital was, there was no difference in between the police transferred patients versus the emergency services. So that means immediate transfer to a hospital was emphasized in this paper. So without like stay and play, just take the patient to the nearest hospital was what this paper was all about. So as I said, it's very important to examine the patient, find out whether the patient's alive, look at the pupils, whether reactive, not, and also whether there are injuries. Try to, especially in stab injuries, it's important to look for all these stab wounds, specifically from head to toe, and also to do a log roll and make sure you know where all the injuries are. And exposure is very important. And then, and also you can do a fast or e-fast of the heart to see whether there is cardiac tamponade. And that's the main indication, or if it is any bleeding from the chest, to do a thoracotomy. The other one, as I mentioned, was for resuscitative purpose if it's a witness cardiac arrest. So I'll just go through the steps of performing the thoracotomy. So basically at the 4th, 5th intercostal level, just above the rib, you make a cut from the sternal edge to the posterior axillary line. And it's very important to get the cut as far as possible towards the posterior axillary line, because when you put the fenestrator retractor, the rib spreading, it helps to open the chest, and make sure the handles are on the axillary side, not towards the sternum, because if you want to extend the cut to a clamshell, that's easier to perform from there. And then once you go through the skin, subcutaneous muscle, and go into the chest and retract, you have to look where it's bleeding from, whether it's from the lungs, or whether it's a cardiac tamponade, or where the source of bleeding is. And if it is from the heart, then you have to open the pericardium and avoid injury to the phrenic nerve, and you have to inspect the heart anteriorly as well as posteriorly, because sometimes you have to sort of lift the heart and look at the back of the heart for any injuries. And if there are any injuries to the heart, you can either keep the assistant's finger there, or you can put skin staplers, use a small vascular clamp, or you can use a proline stitch. And it's very difficult to stitch a bleeding heart, so if necessary, we can give medication adenosine to stop the bleeding for about 10 seconds and then put your stitch. And then also, if the injury is in another location, like in the lung, also you can clamp or put a stapler, or if it's from the heart, you can twist the lung as well to reduce the bleeding. And also, you can look at the aorta. If it is, then we have to do the cut the inferior pulmonary ligament and get the lung to a side, and then expose the aorta, which when you come from the spine up, it's the first structure that you come across, and it's very important not to clamp the esophagus, which lies in front. So, best thing is to, in resuscitative thoracotomy, is to like compress and get someone to compress the aorta so that you can put a clamp, but then it might cause injuries, and if you just need to resuscitate, sometimes compressing is helpful, and then can perform the cardiac massage while you are getting the blood into the patient to resuscitate. But and most important thing is to find the site of bleeding and to stop it. And also the other thing is you can, as I said, internal cardiac massage. And looking into the future of patients with traumatic cardiac arrest, there is selective aortic arch perfusion that can be used where a catheter with a balloon goes in and it's kept between the left subclavian artery origin and the diaphragm, and you can perfuse blood at a rapid rate of 500 ml per minute in resuscitation. This can be used. It's really good so for resuscitation, and if you need to give high volume blood products, this method can be used. And the other that's the selective aortic arch perfusion. And then the other one is emergency preservation and resuscitation. This is rapid cooling of the body, and it allows time for definitive surgical hemostatic procedures to perform. As when you rapidly freeze the body, it reduces the metabolic demand, allowing time for surgical hemostasis to be achieved. So this is looking into the future. Thank you.
Thank you very much, Dr. Samarasinghe, enlightening us about the important part in trauma resuscitation. Please join the head table. Our next speaker, actually he doesn't need an introduction, Professor Reuben Peralta. He's going to discuss about endpoint resuscitation and blood products in trauma and critically ill patients. He's currently working as the Deputy Trauma Medical Director at Hamad Medical Corporation, Qatar. Over to you, Professor Peralta.
And thank you, the organizing committee, Dr. Kirti, Dr. Fahd, for the invitation to this great event. We would like to talk in this trauma resuscitation session about the endpoint resuscitation and the blood products in trauma and critical care. I have no conflict of interest except the, education. I think is the foundation of everything that we do. We are here because we took some education courses or training to be here and provide the best care for our colleagues and the patients. It takes a nation to become really good in what you do. And I'd like to thank Dr. Hassan, my colleagues, and the whole team to provide excellent care in Qatar and in the Middle East. This is Qatar 101 for some of the audience that were not here before. It's enclave in Persian Gulf, around 3 million people population, one of the richest countries in the world, and they invest in education and health care. This is Doha, it's a cosmopolitan city, host of the FIFA World Cup during the date and time. Good things for the Australian folks also. No firearms are allowed in Qatar, and where we see some small percentage of stab wounds, but no firearms allowed. This is our Hamad Medical Corporation, take care of 90% of the healthcare in our country. 90 to 95%. And this is our trauma center, and a state-of-the-art 400-bed trauma emergency center. We have an Australian colleague, good friend of mine, that was working with us before, now he's came back. I think he's from Dr. Mark Place, and Peter Cameron. It's an incredible access to the Middle East and to the globe and medicine. And this is our trauma center. Trauma's surgery team was established in 2007. A few years later, we established the National Trauma System. It was accredited by the Canadian authorities since 2014. And also we report to the National Trauma Data Bank and to the Trauma Quality Improvement Program. And we have a Qatar Universal Healthcare. As I mentioned before, to the Trauma Quality Improvement Program, this is the last report of spring 2025. Around 531 trauma centers in the United States. We have the best performance and overall mortality. And due to the effort of everybody in the team, from the paramedic, injury prevention, our fellowship, education, nursing, and doctors. We'll touch a little bit about trauma resuscitation and orchestration of issues. It's not only done by one person. We'll talk about endpoint resuscitation. What is an NTP? What is the challenges to establish and the sustainability? How do we do the activation and administration? The hemostatic agent that we use, the trauma surgery in couple of case scenario, and the summary. The endpoint of resuscitations are the aim to restore the adequate tissue perfusion and oxygenation. Early identification of endpoint prevent under and over resuscitation, and also secondary insult, especially traumatic brain injury. And we can follow those endpoint resuscitation, clinical, biochemical, and hemodynamic parameters. And the clinical endpoints is restoration of the mental status of the patient. Sometimes it's really difficult because they have a multi-medication. Normalization of the skin perfusion also. They may have a lot of fractures and injury in the extremities, adequate urine output, and a stable vital sign. From the hemodynamical endpoint of view, we usually do CVP, but usually when the patient is crashing, we don't have time to do the CVP. We use cardiac output monitoring that we use now, especially with the non-invasive ventilation, and the mixed venous oxygenation. In the biochemical laboratory, we use a POCT a lot. We use lactate clearance, the base deficit through the ABG, normalization of the pH, and actually we really consider a lot, especially in patients that has a high injury severity score and patients with cross injuries, they improve in the coagulation. Other monitoring, other important that we follow is the normalization of the coagulation derangement. And we use this by rapid INR. This is one of my favorite now because it's quick. And then by the POCT, that is the tech plate mapping and roten. We use non-invasive ventilation, and they are commercial company that you follow. We follow from the pre-hospital and the hospital and the theater or operative report, and also in the ICU. And trauma resuscitation pendulum has been really, 180 degrees since I started my profession to now. And massive transfusion protocol was not available. When I started the trauma program in Dubai, we used to have a whole blood. After that, corporate America came, joint commission. We divide the blood in components because, for obvious reason, in the Middle East we have a lot of consanguinity and blood dyscrasia like thalassemia and familial and so forth, that we use a lot of blood components. But nowadays the pendulum is switching to the fresh blood. I think the truth is in the middle. The truth is through the education. How do we approach the patient, injury prevention? I don't think one is a panacea for just only blood. in my opinion. Said before, this is a patient that came with injury with cross injury in the face, non-compressive injury.
Okay, you can put it on.
This was Asha anti-medication.
Guided embolization that are uncompressible. Those patients, if you don't do that, they will go.
Sir, how many minutes total will you keep?
If you don't do that, they will die of exsanguination.
The 18th of 2020 TRBC, all platelets and SOP and Priya, how much cough you got?
Part of the facial injuries. Doesn't matter if you put, as we mentioned there, a tamponade. That's why the following question about massive transfusion. In reality, these slides right there summarize the whole presentation. If the message that I'm going to bring to you, injury prevention is the key, but control of the hemorrhage or trying to control the hemorrhage is easy. It's easy for me to talk when I have compressible injuries easy, and the extremities, we can put tourniquet and follow with the blood. But the non-compressible injuries are really, really difficult to understand, especially if you are trapped in a building, trapped in a tunnel, or trapped with a mass casualty event. Then we're trying to do is stop the bleeding. If we fail local, we establish endovascular. We have the protocol for REBOA and the hybrid OR. We do resuscitation, damage control, or resuscitation dictum with the media blood utilization. And one of the reasons that we have become so good and immediately, we have established a trauma fridge through the trauma resuscitation unit, or trauma bay, in the OR and in the ICU. So we have immediate 10 units of blood available for those patients. Plus, we activate the massive transfusion protocol. I don't know in your institution, our KPI for target blood is 5 minutes to 15 minutes for get blood if you call the MTP activation. For that reason, to that gap, we have a fridge. So we can wait, but by that time, the patient will have 4 to 6 units of blood and mobilize quickly to the hybrid OR. We are heavily using factor concentrates. We have a vast experience, and we have published a lot about that. And I think for me, the backbone is education. We have established a trauma critical care education. Over 16 fellows has been graduated. And we really are trying to understand the resuscitation knowledge, and we have gravitated from the lethal triad to the lethal diamond concept. And as you can see, calcium is a really important, and fibrinogen as one of the 2 most important elements of that concept. Then the question came out is why trauma programs should have an NTP or massive transfusion protocol? Well, it's really obvious. A hemorrhage is the most preventable cause of death in a trauma center, and it's associated with a severe trauma coagulopathy. It's the leading cause of death in the first hours in those severe patients, and is responsible for 80% of the OR for those massive bleeding. This is changing, but if you see Juan Duchesne a story for the last 2 decades, we have not really decreased too much of the hemorrhagic associated death. Is hovering around 38 to 42%. Doesn't matter how much we've done. Because it's multifactorial. And I see we were focusing a lot on the lethal triad. For example, here we may not have to worry about too much about hypothermia unless you use a lot of cold resuscitation fluid. But in reality, we're missing a lot of votes where we don't replace the calcium. The calcium could be consumed for many things. For the coagulation, there is no factor. For the pH, when you have a pH, really low pH, your calcium is, is decreased. For the hypothermia, it's not the same. And also for the blood component that we use. Most of the blood components are citrate preserved. And citrate is a chelating agent for the calcium, so we have to replace it. And we use protocol that Professor Su mentioned, the protocol to really avoid the variability if it's at 2 o'clock in the morning or 2 o'clock in the afternoon. Everybody has to follow the same. And this is a case that I tell you is for example, 70-year-old gentleman that comes to you after fall with identified lesions and by the CT scan. We used to do the TEC 5000 fellows. They were, a little nonsense because we had to do in the pipette. Now it's being replaced by a cartridge. And I think one of the reasons that we have to address issues using the rapid INR when we can have a INR by conventional measure in less than a minute or two. And then we can address the coagulation on this point. This is a rapid INR show, and this patient was 4.0. The patient has no comorbidity regarding coagulation issues. They were not taking warfarin or Coumadin, and those injuries in the brain, they may develop this. We have a protocol, and we use the resuscitation pathway with program with major protocol. Depend if you're using TEG, thromboelastogram, or we're using Roten. Everybody is written. The nurses are now empowered or rolling over the program. And this is our state-of-the-art protocol for resuscitation, especially in severe bleeding patient. Patient come with a crash. We start with a blind resuscitation, and we do rapid INR and rapid fibrinogen. We give it 4 grams of fibrinogen in those patients, and needed 2 grams now of the tranexamic acid, and now we continue with the blood products. After that, immediately they go through the Roten and TEC pathway, and then we offer them a guided resuscitation pathway. As you can see, we have in an epidemic now because of a patient that has a platelet dysfunction syndrome. And I think we use Riboa for a non-compressible hemorrhage. We activate the Riboa code. Everybody's involved, from the anesthesia, the emergency personnel, the trauma OR or trauma theater, depending how you call them, also the radiology and technician, and the interventional radiology. Then this is the patient that come to you with the rapid R displacement and the TEC, and then really what he needed was FFP or PCC, and then instead you save a lot of the other blood components. As I mentioned in my previous lecture, in Qatar, due to regulations, the components are really expensive. 1 unit of RBCs is $1,000, 1 unit of plasma is $1,000. So, and an activation of 666 of MTP that we designed is $20,000. So if I can save there probably $14,000 in this patient. So it's something really important to mention for you local resources. We are one of the few places that we have platelets available immediately. Meanwhile, most of this publication has been done by the Chestnuts. They only use plasma, or they use PRBC. We use platelets. Platelets is an important component. So I don't think we're measuring apple to apple in this case. And this is the TEC after PCC or phosphorescent plasma, you normalize the curve. So this is the implementation history. We described our program in 2018, and where we established the all TEC. As you can see, we were guiding it. There was a log. Every fellow has to do it in a pipette. Now it's being replaced by the TEC 6S Sigma, which will really is a cartridge that is automatically displayed, done by a nurse. And this is a patient, 70-year-old, with dual antiplatelet with mechanical injury fall from standing, severe traumatic brain injury. All Rotens are normal. All coagulation profiles are normal, including the platelets over 140, but he has 90% inhibition of the 2 channels, AA and ADP. Why? Because you are in dual antiplatelets. If you don't replace this platelet, this patient will code in the next few hours. So that's, I think, is important. One thing is to reduce the coagulopathy. Another thing is that the reduction of the coagulopathy may transfer into survival benefit. We have to understand that, and that's what we have to tell the family what you have. We have extensively published about trauma resuscitation, required massive transfusion protocol, and a description analysis of the role and timing of those products. We know that 4 hours is the key for us in our population if we replace the coagulopathy. And just to give you at least 1 minute, one thing is talking a lot, and I think that's what I asked you, Trauma Center, to provide regional quality improvement program. We use the TICWIP, and in the TICWIP we have this, we really match apple to apple. We have to see the process, the structure that we use, and the outcome. And that's what I think is important. One of the benefits that we have seen recently, benefit for a blood product, has been the establishment of the trauma fridge along the way of the continuum of care of the severe trauma patient. NTP has been 15 years with us, and February 10 we're going to have the 16-year anniversary. It's a big thing. It started by the trauma program, and now everybody uses it. OBGYN, the whole country uses it. We use it for the FIFA. It's an incredible program that is Qatar program. We established in the trauma center. This is activation. The most important thing is effective communication with all the patients, and it's a worldwide program. It's a corporation program now at the 17 hospital, and we just have to mark 29151, and this is activated. This is the only program activated that doesn't need Cerner, doesn't need written prescription, and you have to follow up. When, how, you activate it anywhere, and the evidence shows in the meta-analysis that we provide that actually we are lower when we use our mortality of 30% for the meta-analysis when you use no use NTP with the 42%. Prediction of the activation, we use a Facile score. It's something that we have created. It's a fast positive, shock index, and lactic acid. Also, we use the ABC score and the shock index usually. This is our massive transfusion protocol that has got rotated and transformed to a state-of-the-art protocol. There are complications with the MTP, the trolley, the taco. It's not the taco that I'm going to eat in a Mexican restaurant. It's the trauma-associated cardiac overload in patients that has, especially elderly patients. This is our management. In summary, it's important to have your resuscitation protocol based on education, also and active the product, and this has been our incredible service for us. We cannot do this alone. We need a village. We need a nation. We need a leadership, a collaboration from everybody, from the nurse and the pharmacy, everybody to do this project. This is our road for the last 15 years from the incredible Qatar based on the trauma education. And I'll invite you again to come and visit Doha, Qatar from November 12 to 14 with 3 major congress is going to join us. That will be Qatar Health 2026, the World Surgery Congress, and also the World Congress of Trauma Education and Simulation is going to be in Doha, Qatar. Bohoma is tutti.